Morning, guys. We're going to talk mainly about laterals today and the technique associated with premise and goal for me is to simply be able to walk you guys through the basics of the procedure, and then a little bit about positioning and things like that, and then sort of having a reference for at least the fellows to safely and efficiently be able to get through a lateral. So when we're talking about XLIF or lateral, we're mainly talking about the lateral corridor to the spine. And here you can see all those other various exposures, but we're really talking about a retroperitoneal exposure that'll get us access to the spine from the left or the right, depending on the patient anatomy. So this is a procedure where technique matters a lot. There's certain parts of what we do where the technique may not be as important. For instance, an ALIF, whether you have nuances about how you do your ALIF, that may not matter that much as long as you're able to get the end plates clean and the implant in. For lateral, as you're doing the approach and we're dealing with neurologic and vascular structures, the technique really does matter. So we're going to talk about some anatomic considerations, some logistical considerations, and how we're setting the room up and positioning the patient. Those all are important. And then obviously neuromonitoring is really important, as you are in large part control of that, and your interaction with anesthesia will be really important. And for many, this ends up being a new approach. And because of that, it can be a little bit dicey when you're on your own doing it. And then obviously an efficient prep of your fusion bed is critical. But in this case, it may have a time-dependent importance. So there are some obstacles to adoption. The room setup is different. Not many surgeons right off the bat are used to setting up patients in the lateral position. You got to get monitoring all taken care of. It's a little bit of an unfamiliar approach as we're going into the retroperitoneum. Oftentimes we're using smaller incisions and having to navigate complex structures. And often it's not a single approach surgery. So sometimes when you're doing deformity surgery, you're going to do it in 2 stages, or even the degen work that we do. Oftentimes it ends up not being in a single position. And so that can be an obstacle, as can cost if you're not careful. And then if we're still using radiation as a primary source of visualization, then that can be troublesome too with regards to the effects of fluoroscopy. So those are all things that get in the way. When to do laterals, well, I think the indications are obviously most important. We're not going to dive into that. It's kind of what this year is about for you guys on the fellowship side. But you do need to figure out what you're really trying to accomplish. Are you trying to have a minimally invasive approach to the spine? Are you looking for indirect decompression? Is fusion on the docket of things that you're trying to do, segmental alignment, global alignment, and deformity correction? And obviously, these are all things that you can accomplish from the lateral approach, and things that you'll see throughout this year. When would you not do a lateral? If you've had a previous retroperitoneal exposure, that's not an absolute contraindication, but it is something that you should be aware of. If the patient has neuroanatomy that's maybe different in some ways, if the psoas are super anterior or 4-5 is in the presence of transitional anatomy, there are things that you have to consider and assess risk and whether or not that is something that you want to do. Again, vascular anatomic issues, obviously fusion is not indicated, don't do a lateral. And then how comfortable are you with the procedure? And if you're not that comfortable, well, then doing a complex 4-5 spondy may not be the right procedure for that patient. So a couple other things, expectations of both the surgeon and patient. I think understanding what those expectations are on your end and on that of the patient's will also help you understand whether or not this procedure is the right thing. But certainly there's a learning curve associated with it. And you have to understand the normal physiologic response to surgery. And the more you do of these, the more you'll understand that comment. But whether it's some thigh numbness or pain, etc., those are things that can be a natural physiologic response versus having weak quads or Tavance or other neurologic issues. That would be a bigger deal. And then know what role you play as a surgeon in minimizing those side effects and potential complications. And hopefully this talk will kind of get you a little bit closer there. So there are some nice anatomic studies looking at lateral. This is kind of one of the hallmark ones that was done here at UCSD by Gilad, who was a fellow of Dr. Garfin and Dr. Kim's at the time. And they did a nice job of sort of defining the safe zones. They took basically 100 human MRIs and looked at the zone between the vasculature and the nerves, and found that the higher up you are in the lumbar spine, the safer things are, and then the lower you go, the less safe they are, or the smaller the safe zone is, I should say. That's a better way of defining that. But this makes sense just because of the neuro and vascular anatomy that exists, and you can see that as you go inferiorly, a lot of times the lumbar plexus is going to be coming a little bit more anterior, and then at the same time, the bifurcation of the vena cava into the iliacs and aorta into the iliacs will end up making those structures more posterior lateral. So also be aware of transitional anatomy. This is kind of what I was talking about in the previous slide, is that when you start seeing these like little Mickey Mouse ears is kind of what we call them, what that means is that the transition of the psoas going more anterior frequently means that the lumbar plexus is also going more anterior. And it's not that you can't perform the surgery safely, but the corridor for that safety margin is not as big. So just be aware on these patients. In general, this is a sign until you're more in the more experienced category. This is someone that you will not do a lateral on. Again, vascular anatomy, just make sure that when you're looking at MRIs that you start really looking at the vascular anatomy and the neuroanatomy. And I would say this is a great thing to do while you're in the office and clinic, because you can start looking at these structures almost immediately, and on literally 20 MRIs per clinic, and always be aware of them, like things that you're always taught in our basics of radiology, like look at all the things that you don't usually look at first, and then go to the anatomy that you're most interested in at the end, just so you don't miss things. But just to point out the approach, the retroperitoneum is a pretty large area, especially if you have a patient that has a little bit of extra weight. So this ends up being a really good approach in patients that are overweight, because the safety is a little bit bigger. Safety is not as big of a concern with regards to retroperitoneal access, as that potential space ends up getting a lot bigger there. Just be aware of, again, this is just an image showing, the vascular anatomy on this one patient at L4-5. You can see just how lateral these vessels are. So this is a little bit of anomalous, but if you think about a Cobb elevator going to the contralateral side, that could potentially be a problem in this patient. So just always be aware of that. And then again, Reg Eb looking at the anatomy in 3 groups. He looked at the normal versus spondylolisthesis, with those with spondylolisthesis and those with scoliosis, and just basically showed that as the patients have more scoliosis, that corridor actually narrows a bit, especially on the concavity, where the nerves will migrate posterior, but the vessels really migrate posterior as well. And kind of what they're talking about here is, as the spine rotates, you can see the vessels rotating as well, and that can lead to a little heightened concern for us. One thing we do use a lot of is what we call directional neuromonitoring, and the idea here is that you have a neuromonitoring lead that allows you to, with a higher degree of accuracy, know where you're stimulating. And if you look at the little probe there on the left, the black probe, at the very tip is a little arrow, which basically tells you where that signal is being sent out. What that means is if you're pointing at posterior, it's only going to pick up what's happening posterior versus a probe that sends out a pulse in general, in a 360-degree pulse. You don't know if there's a low value. You don't know if it's in front of you or behind you or above you or below you. So that's an important differentiation when you're using these. You always want to make sure that you have a device that can give you some directionality. This is just looking at the lumbar plexus. If your dilator is here, your initial dilator, that's bad. So if you have both anterior and posterior low signals, that's a get out of dodge moment. Don't do that. You got to reposition in that area. If you're happen to be behind the nerve, which is also really bad, you'll have low signals in front of you, but then normal signals behind you. And then obviously this is kind of where you want to end up being, which is you have low signals low signals behind you, and basically fairly normal signals everywhere else. So this is kind of the anatomic representation of what we do there in the operating room. What if the thresholds are low or continue to be low? You always want to do a few things. Check for patient positioning. It happens that after 5 or 10 minutes of just laying down on the table, that the patients can shift even despite you taping them down really well. So always just check your AP and lateral to make sure that the patient hasn't changed in position. Use the directional capabilities of your of the monitoring to find out exactly where the danger zone is. And then typically, I would recommend pulling all the way out of the psoas, repositioning within the psoas, usually more anterior, and then hoping that you find a better corridor. If you're at L4-5, a lot of times we're docking a little bit more anterior and then manually translating the retractor posteriorly. When you get into a spot that you like, just make sure that you have enough space to work, and then certainly watch your free run during those translation maneuvers. You can manipulate the docking pretty simply. So if you're getting in a spot like right here, this is not an ideal location to do your lateral because you're super anterior. But certainly you can then manipulate the retractor, move it more posterior, use the direct stim to make sure that you're in a good spot. Check your lateral, obviously, to make sure that you're still in a good position. And once you've moved back, you should have something that looks a little bit more like this, which is now in an acceptable location to do your lateral work. And here's just putting a 22 millimeter box cutter, a 18 millimeter box cutter to see what that would look like. And you can see we're well within the limits of acceptable there. Couple things on neuroanatomy. We talk a lot about the genitofemoral nerve. Interestingly, as much as we've talked about this nerve over the years, I don't feel like I've seen as many problems with it. I think we saw this much more often early on, and I think with a little bit of change in technique, we haven't had too much of an issue with it. So if you look at the little zones at the bottom, 1, 2, 3, and 4, in general, zone 3 is considered to be a safe anatomic corridor, basically from L1 down to L4. So you're okay docking on that like 25-yard line or so. And then as you go further down, the genitofemoral nerve does kind of sneak into zone 2 and zone 1. So just be aware of that when you're dealing with neurologic structures, particularly if you're doing some direct visualization, you'll be able to look down your tube and see sometimes if there's a nerve in the way. So in general, if you're in L1, L2, down to L3, 4, zone 3 is good. These are all pretty safe. And then just avoid these areas in the other zones, or at least be aware of it. The problem is you can't monitor that nerve. So it's a sensory nerve that we don't do very well with monitoring. So for 4 or 5, positioning is super critical. We used to break the table a bunch. Now we don't break the table hardly at all. Make sure you're doing single passage through the psoas. And the over breaking the table, basically you were stretching the psoas and the lumbar plexus a lot more, so you're bowstringing it. So we feel like if you break the table too much and you put too much tension on that muscle and those nerves, that they have a higher instance of being injured. So if you leave them loose, then they can move out of the way. So we'd rather use angled retractors without breaking the table than using straight retractors and having the table overbroken. Utilize your neural monitoring again. Minimize your opening of your retractor, so that's the actual physical opening. Try not to have too huge of an exposure. Use angled instruments when needed, and then just remember retraction time matters. We like to have our goal retractor time less than 20 minutes. If it looks like you're going to go more than that, just collapse it down for a couple of minutes and then open it back up. Those are some painful 2 minutes, but I think they can be really important in keeping things from going the wrong way. Here's just a view of what these angled instruments look like as you're manipulating around the crest. Here's what it is in the operating room when you're docking at an angle and then doing the procedure at an angle. And so, again, experience is really important just because on the lateral view, it's hard to see what you're doing. You'll be using a lot of AP views to do all that you need to do, both from the COBs, the other tools that you may use to try to get your implant in. But you can see that it can be done safely and efficiently. So when it comes to fluoro, do not accept anything besides a really good view of your disc space. You want to get a true AP. And that means that you can see the pedicles perfectly and that you see the spinous process basically bisecting those pedicles. A lot of times you have to pick one level or the other because you may have a little bit of rotational deformity. My preference is to pick the caudalmost level as the one that I'm going to try to get dead on. And then I'm okay with the one above being a little bit twisted. But that's just usually how I like to do it. And then I always manipulate the patient. I never manipulate the C-arm. My goal for the fluorotechs is that they come in and literally only have to go 90 degrees, AP lateral, and that's it. I don't want them to do any other work. And so we're talking about just keeping things midline. And unfortunately, it looks like my little arrows are off. True lateral, same thing. Never mind the arrows; they're supposed to be pointing up at the foramen. But you can see how perfectly you can see the disc space as well as the posterior inferior margins of the bodies of both levels. You really want to see this as best as you can. You want the pedicles to be superimposed, and again, you want this to be easily captured from the fluorotech, again, going quickly AP and lateral. So patients that have bigger deformities, sometimes this can be a little bit of a struggle if you're trying to come from the concavity. You can see that you would definitely be in the abdomen if you drew a straight line. We're clearly not going to be doing that, but just be aware that bowel injuries have been reported, and you have to be conscientious of that. The technique actually doesn't change at all in this setting, except that sometimes you have to have a little bit more of an anterior incision, but you still need to get into the retroperitoneum the same way. When people talk about left or right-sided approach in general, we have tended to go towards the concave side. This allows a little bit better of a release, and also usually allows you to capture L4-5 as part of your construct. You can see on this image here, if you were to approach from the convexity, you couldn't get down to L4-5. It would be too much of a struggle. Plus, if you do from the concavity, you can usually get almost all the levels through a single incision, which is nice. So subsidence can be an issue. So just be aware that we like wider implants for that reason. The more we increase the surface area, the lower the pressure will be on the disc space itself. You want to choose a length that covers the apophyseal end plates. You don't want to be short so that you allow that implant to subside into that bone. You really want it on the apophyseal ring if you can manage it. And again, that's the power of the lateral, is that it's really covering and engaging the stronger parts of the end plate. And if you look at going from a standard to a wide, the subsidence rates will drop dramatically. And that just makes perfect sense, right? Just based off the discussion we just had. They also have even larger implants now. They go up to 26 millimeters wide. And the resistance to subsidence is appreciable from that as well. So I want to get good end plate coverage. Don't overstuff the implants. Be careful when you use BMP, which many of us don't use anymore, and then go wide as much as you can. So the next little section is on doing the actual procedure. You want to be consistent and efficient. You want the process to be simple and elegant. You don't want to waste any steps, and you want it to be very reproducible. So here's sort of my little mantra on how I do this operation once we're docked. You do annuliotomy to a cob, pituitary, box cutter, pituitary trial, and plate prep and implantation. So we'll kind of walk through these steps. It's nice to have these retractors that are able to keep the corridor nice and narrow for you, and that's just showing what I like to do. And then as far as when people are saying how, is my aperture big enough for me to do the work, you can always grab a little trial, or this is a box cutter, to see if you have enough annulus exposed to do the work you need to do. So first thing is just get your annulotomy. I take my time with this part right here, actually. You can go to about 30 millimeters in depth, which is about twice as long as the blade itself, because the end plate diameter here on the AP is probably more like 45 or 50 millimeters, but you can pretty safely go in about 30, and I like to loosen up that disc space as much as I can. And then I go straight to the cob. I don't start working with pituitaries and stuff because I just don't like picking very much. So once I make my annulotomy, I go straight to the cob, and then under direct visualization with fluoro, you're able to visualize that end plate and denude all the cartilage off of it in one sweep. You want to get right on that interface between the bone and the cartilage. That's super critical, and this is probably the most important step of the entire procedure to make it efficient. If you make this part inefficient, then you'll find yourself picking for a lot of the case. So you get right along that end plate and allow your hand to shift. If you look here at where the cob is relative to the retractor, it's at an angle. And then as we work our way through the contralateral side of the disc space, allow your hand to make the adjustments so that you're straight in and then able to get across the other contralateral annulus. I'm just showing you here that a lot of these instruments, some of them have the transition zone for the cob that's a lot wider. Just be aware, sometimes that can actually put a bump in the bone if you're not careful. And then again, you want that cob to go all the way through the contralateral annulus to get a good release there, and then come back and do the other side, and same step there. Next, I go to a pituitary, and the idea here is to take out bulk. You don't have to worry about debriding the disc space much more than just go in there with a couple passes, get out what you can get out, and then don't sit here and pick, because the next several steps will make sure that you get the entire disc out. Always know where your tip is. That's really, really important, because you may be deeper than you think you are, especially early on in your career. Just take extra fluoro shots just to make sure you're very comfortable with where you are. And nowadays, if you're using nav, that may be a moot point. But and then the other good principle is never enter the disc space with your tips open, because you may drag something. A little bit more controversial. I know not all of us use this. I love it. It's a wonderful way to get rid of the disc out of the disc space. I like to make fun of it as the ALL lacerator, the fellow ALL lacerator, but it's actually not. The main trick here is that you have the box cutter actually seated within the disc space, like by a few millimeters before you start hitting it. And the idea there is you just don't want to drag anything with you in there. Sometimes if you catch part of the annulus and you hit it in, then it can actually rip off the anterior annulus. And that's what this slide here shows, is just, if I usually use this pretty small box cutter to get in there. And then if you feel that resistance stop, like if it's bouncing back at you, because that means you may be grabbing something and dragging it into the disc space with you, which could be the ALL. You also want to make sure you have a really good view of this, so that you want to make sure that your box cutter is orthogonal. So that's what it should look like. And again, we're using perfect AP and lateral images to guide us, so that if your instruments are perfectly orthogonal, then you should be fine. And then sometimes you got to clean it halfway. Sometimes you go halfway, take it out, clean it, because you're getting so much disc out with it. And then take it to the contralateral side and release the contralateral annulus. You can even see here nice correction that you get with just putting the box cutter in. You can take it to the contralateral annulus if you need to. And then I go back in with the pituitary, remove any of the remaining debris. And a lot of times, like what you get out are like big chunks at this point, which is really nice instead of having these tiny little threads of tissue. And then I go straight to the trial, and you may still feel like you haven't totally debrided the disc space yet, but I guarantee you, once you're done trialing, if you did a good job with your cob, like everything will be like it'll look pristine. And so I usually start with an 8 mm. The main principle here is if you don't feel like you're big enough to be able to get a 22 mm cage in, if you just go simply by math, if you can get a 10 mm tall by 18 mm implant in, that means technically that's actually larger surface area than an 8x22. So I feel like in general, you can almost always get a 22 in. There are certain instances where you can't, but in general, I think it's a good principle that you're able to do that. And then just trial to the size that you needed to go. And then once you're done trialing, check a lateral, make sure you like where you're at, and let the back table know which implant to prepare. And that's important to do at the end of your trialing because you're about to go do some end plate prep. And so you can use these stirrup curettes and puncture the end plates if you need to, irrigate the wound. If you're done doing this before the implant's actually ready and loaded, then just release your retractor so that you give the patient a little bit of break through that. And then finally, placing your implant, you can either use graft containment devices or you can use these slides. Especially at L4-5, I use the slides almost every time. I think they're a little bit safer with regards to subsidence and hurting the end plates. This device that you see here, these aren't slides, is actually a graft containment device that's we're able to put the implant in with. And that's your final product. And so this is a video. It also includes an ACR, but just to kind of show you live what it looks like to go through this from docking and getting your retractor in the right spot. Here we have you also have an anterior retractor that I showed you there, which plus or minus on the tending's using. I don't typically use one. And then here you see just denuding those end plates, like we talked about, and then going to the box cutter, cleaning the disc space out. And then here I cut the ALL, but so I apologize for that being part of it. And then distract the two bones from one another just to show that you can get that you got a full release, and then you can put your implant in after that. So same basic principles, minus cutting the ALL, which should not be part of your routine lateral. So good. Again, be consistent, be efficient. Process should be simple and elegant. Don't waste steps, and be reproducible so you can get a reproducible outcome. Thanks, guys. That's it.
Bam. Hey, Greg, one question. So you go 8-18, so you're just trying to like kind of establish the space. That's why you don't go right to a 22 width?
Oh, no, I go to a 22 automatically.
Your first trial?
Yeah.
Okay.
Yeah.
And Hanny, I do not. So, it's funny. I listened to Greg give this talk, and, my disc prep routine, my setup routine, just a little bit different. But I think the key take home messages for the fellows is you got to pick a routine that works for you and then stick with it. Stay consistent, do the things you need to do to make sure you stay safe and appropriately aligned, stay out of the end plate, all the things that you need to do personally to make sure you're doing this efficiently and safely is the key.
Yeah. And the thing that's awesome for you guys is you're going to have access to like 3 or 4 different people that have basically been doing this since its inception. So you're going to have such a good like armamentarium of different ways to do it, whereas it's not necessarily all fellowship experiences. So you guys be really hooked up.
Yeah, I think we do variations on a theme. I'm not sure we do it differently. We just do variations on the theme.
Yeah, I just mean that it's not this like algorithmic like workhorse. It wasn't in my fellowship for sure. You're just kind of like figuring out as you go along. So it's nice to have such a reproducible, I think, set of steps.
Cool.
Awesome. Thank you. That was a great presentation.